All right. Welcome, everybody. Welcome to yet another Compliance Capers in the month of March. Hey, my friend. Good morning, Betty. How are you?
I'm good, Sonal. How are you doing?
I'm good. I'm so good, my friend. So, again, we are continuing our conversations about the OIG work plan and specifically completed reports that I thought were really, really interesting for our community here to understand better, right? The vast array of work that we've talked about in prior weeks from the OIG work plan. I wanted to continue talking about something different, right? Last week we talked about psychotherapy codes. We've also talked about ophthalmology space. We also gave you guys the rundown on the background, right, of what the OIG is doing and why they are conducting all of these projects throughout the year. So, for today's conversation, I wanted to kind of pinpoint pain management services. And, specifically over the years when you and I have had the opportunity to work from time to time with these types of providers, in years past, LCDs and LCAs were different, right? And so this particular report that happens to be closed out on these types of spinal facet joint injections, kind of hones in on the fact, and we will, pepper our conversation today about the facts that the local coverage article happened to change right in the pandemic. So I know throughout the conversation we will talk about that, but I wanted to sort of discuss it right up front because they made a pretty significant change, in my opinion, to this, group of specialty providers during the time of COVID. And so a lot of us in the background here that do the work, as well as the CMS, everybody was struggling in 2021, right? Things were shut down. You had to not go into the office. And so, when I read those details throughout the report, it gave me pause. Like, okay, so this education wasn't really stressed upon too much because who knew about it, right? Maybe the Macs weren't really pushing the education out again because they weren't in the office, right? They were remotely working from home. Their job description changed for a bit in 2021. So that's how I sort of looked at this report. Again, it is lengthy, not as long as some of the others that you and I have talked about, but of significance as well as this is a report that does affect the entire country. So all of the Macs, were experiencing this change from that LCA back in 2021. So, I just thought that was really, really interesting. And then now a lot of our providers, are going to be experiencing more than likely recoupments, right? Based on some of these really intricate findings from this particular report. So I'd love to hear some of your thoughts on this one, Betty, while I find the link to put up here for our audience to just gain kind of a general oversight on what the general OIG work plan summary is. And then later I will tell you all the exact article number where the report is actually found. So then you guys can also pull up the greater report. It's about 30 or so pages.
Yeah, I think it's like 32, something like that. So yeah,
30.
it's right around 30. Yeah, and in this one, to your point with the LCD and the LCAs too, I thought it was interesting that in this report, the OIG actually kind of calls them out on that too. So it's remember when these reports are done, the OIG is not just looking for what the practices or hospital or clinic or whatever they're looking at, what they did wrong, but they're also looking at maybe if there's inconsistencies or if things are not being reported correctly, why? Was there some other reason behind it? If something new just all of a sudden seems to crop up. And so I did think it was interesting. One of the recommendations and one of the things that the OIG repeatedly says in this report is that the LCDs came out and then the LCA, the article, local coverage article, explanations came out, and then the MACs really didn't, some of the MACs didn't educate on it at all. And so they kind of called him out, for, hey, you're putting these things out there that a lot of providers do, and then you're just saying, figure it out. Which, I mean, technically, do they have to? Yes, they're billing it. Their tax ID numbers on it. They need to understand what they're reporting. But traditionally, if these are things that have been educated on and they put an LCD out for it, they should tell people what that entails and what's different now and what they should be doing. So that was one good thing. And like you said, we'll probably touch on this a couple times because they do state it a few times in here. But what they were looking for, or what they were looking at in this report, was the facet joint injections and the facet denervations. So when they're looking at it, patients will get these that have arthritis or injuries to the facet joints or other kinds of conditions. And so they will try to give them some injections and sometimes end up having to do denervations, which is kind of like killing off that nerve center for pain relief for these patients. So these are patients with severe chronic pain who have tried other therapies like PT and things like that, and it's just not doing the trick for them. So they, move into these injections. So their objective when they did this, the OIG is stating is whether they were paid for the joint injections correctly according to Medicare guidance. So, what their documentation was, what their 1500s were, and, were they, paid? How were they paid? Does the documentation support what they were paid? Are these things that the MAC should have maybe been looking at? So I like on this, the background that they give in this, when you look at the report, for those of y'all that want to look up the report as Sonal pulled it up here, when you do it, one of the things we were talking about was on pages 2 and 3 of the report, when they give you some of the, background information for what they do. I think that sometimes people, when they see that kind of stuff, they're like, oh, well, I do these, I know what they're talking about. And they kind of just gloss over that beginning part. But with the facet joint stuff, you can do the just the injection, or you can do the denervations, which are done with a heated needle, and it has to be heated to a specific degree for it to do the work that it's supposed to be doing, for it to get its objective, which is one of the things that came up in one of the reviews when they were doing these, was the fact that the heated probe wasn't hot enough, according to what the guidelines state. So, I mean, they get that specific when they're looking at things. But, they go through and show you what the difference is between them. They list out the CPT codes that are used to report these, and the fact that they're add-on codes, that they're done by level, that they're unilateral. So if you do bilateral, you want your modifier 50 coming into play here. And in the report, whether it is a denervation or an injection, they call them all interventions. So if you don't read that background stuff at the beginning, when you're getting into the report and you're looking at this intervention stuff, it could be confusing because you might not necessarily understand what they're talking about. So it's important when you look at these OIG reports to actually look through that background stuff and make sure that you have in your mind the right idea of what they are discussing when you go look through it, or else it's just going to be confusing the whole way throughout. So that's what they're looking at and seeing if the documentation is supporting it, and if they were coded and billed and paid appropriately, which The OIGs, chances are probably not. If the OIG is in there taking a look at it, it's because there's been some question about it. Excuse me.
Absolutely true, Betty. Yeah. So, these types of facet joint injections, spinal pain management services have been looked at for quite some time, right? So, the rationale why the OIG work plan project had started. Okay, I'm going to read to you from the OIG work plan summary itself. And it says the Medicare Part B covers various spinal pain management services, including facet joint injections, facet joint denervation sessions, lumbar epidural injections, and trigger point injections. Medicare Part B also covers sedation administered during these pain management services. We will audit whether Medicare payments for spinal pain management services billed by physicians complied with federal requirements. Right. So in general, that is the basic rationale for what was going on in this particular report. It is A-09-22-03006. And so in general, as we had stated, they were looking at a cross section of claims that they randomly and stratified the sample, and they do list in one of their appendices, again, their exact methodology for how they, stripped and obtained this collection of sampled records alongside claims. So, when you work with your own practices to perform little sample audits and things like that, you do want to try and use a objective methodology, right? And so you can review these types of large reports to see how it is the OIG is, honing all of these particular samples in. And so for all of these reports that we've talked about during this month, they do provide you in that appendix exactly how they obtained their 100 samples, based on a larger review of what they were trying to get at, again, from across the entire country, from each and every MAC. So the whole report, in our opinions, is a must to read, right? Because just because, like you were saying, your provider, they're providing pain management, you really do need to understand the complexity of the definition of this particular group of CPT codes, right? So although they're not that many, alongside the add-on codes as well, again, it's complicated because they are combining both the diagnostic injection alongside the therapeutic injection in the CPT code definition itself, right? And so the greater, findings in that local coverage article in the end, right? They change things up to help the community out by, helping understand what you're billing. Because if both diagnostic injection and therapeutic injection is in the definition itself, there is a frequency limitation, right? That we have to understand based on the LCDs across the country. So how are you going to know what you're doing if there's no modifier that's been added? And so that's what they did during the pandemic. They added the modifier KX to help providers understand what they're going to be doing for diagnostic versus therapeutic. And so a lot of these findings, as you trickle down and read through the report in their examples in these little charts, is that, this could have been, supported with the diagnostic modifier of KX. But again, the provider just did not know, right? But so that's when they went into the records, et cetera, and they could see, well, this could have been supported
Yeah.
but that modifier was not actually appended to it appropriately. So,
and I think it was good on page 6 of the report that they laid out how complete and even the audit was to do these. It says, they had 120 records is what they used to, make all of the extrapolations and things here. But it states there that 35 of them were diagnostic facet injections, 43 of them were facet denervations, and then 43 of them were therapeutic facet injections. So, they really tried to make a nice even thing. They didn't, overwhelmingly do one over the other. They want to make sure they were thorough and even in looking at it, which is always a good idea in your practice, to make sure that if you're looking at a particular issue, to make sure you're looking at all of it, in a well-rounded manner so that you get a good idea of where everybody's sitting with stuff when you look at it.
Exactly. That's a great point. So, in this particular report that I happened to pull, like I stated, in the CPT code definition itself is a bit compounded, right? Which means their findings, they had to strip down and put into different buckets as well. So Betty, I know, really likes a lot of these particular charts that they include throughout the document, like the big one on page 7, right? Yeah, there it is.
Yeah, when you look on page 7 again of the report, that's where they give us all of our good findings, out of the 120 total that they looked at. And I think, once again, if you do these kind of procedures, you'll want to look at this because this is showing you where they found the discrepancies or the noncompliance. And me being, the numbers nerd I am, also, converted them into percentages too, so you can kind of pull that out. But it'll show that from the facet joint interventions. And again, they use the term intervention to mean it could be an injection, it could be a denervation, could be diagnostic, could be therapeutic, just all of them in general in that bucket. That out of the 120, 27 of them had to do with the number of levels or facet joints. Now, as we look at some particulars in another minute here, I think it's real interesting that they're going to look at either way, over or under reported. So that's something to keep in mind. So 27 of those out of the 120, so that would be 22.5%. 20 of them hit limitations of coverage requirements. So that's 16.6%. Ones that were requirements related to indications of pain were 19%, or were 19 or 15.8%. Same with requirements for facet joint denervations. There were 19 that did not comply. So that's another 15.8%. Then requirements for diagnostic facet joint injections. There were 9 of those that didn't comply. So that's 7.5%. And another 9 that did not comply with requirements for therapeutic facet joint injections. So another 7.5%. Now, the other thing with looking at these, and some of them, there are some of them, and they've stated it in here, some of them didn't meet requirements more than in one area. So one record could have multiple of these non-compliant issues in it. So they're not just straight all separate, because if you start adding up the percentages there, you're like, oh, that kind of doesn't add up to the 66 that they said didn't match, because some of them had multiple things wrong with them. So that's the other thing to look for, that when you're looking at it, you have to look at it kind of in its entirety and total to see there may be multiple things that need to be addressed for one record when you're looking at it. So, you can compartmentalize to add things up, but you have to take that kind of with a grain of salt, or else sometimes it looks like it's a huge issue where it might not be as huge, but they did a good job with laying it out there. And, to your modifier point on that page, at the bottom of it, they start about the diagnostic versus the therapeutic injections, and the modifier KX. was used to indicate, or is used to indicate, that is a diagnostic injection. And the reason why that's important is because, Medicare only pays for 4 diagnostic and 4 therapeutic over a rolling 12-month period. So if you're doing diagnostic ones and not putting that modifier on there, they're going to assume it's therapeutic. So if you move into therapeutic ones, you may end up getting rejected for doing more than what they've approved for that 12-month period, when you really haven't, because you forgot to put that modifier on there. So they count them as you send them. If you don't put the modifier on there, they're going to count it as therapeutic. So, it's stuff like that when you go down through and look at these things, that you find those little gems that we like to find, the little nuggets, in these reports, at how they can be helpful to practices when they're looking at their own things.
Exactly. And you said that really, really well, right? On multiple points. When we are auditing things, that's how we do it, right? Because each service line has so much that goes into it. There's so much criteria, right? Especially if there are LCDs and LCAs involved. So you are going to have to compartmentalize, put things into, specific buckets, like these reports do, like you and I do all the time, right? So it's really, really helpful to look at your service lines and strip it apart, right? To help you understand how you can improve things from area to area, instead of being overwhelmed, right? And not understanding the complexity of these CPT codes. Because again, they have not changed in all of this time. They are still combining everything together. So I think it's a good thing that they've come out with this education, with this LCA, that, does provide the greater education to help do the coding side of it, quote unquote, better, to help the providers understand, right? Which ones are for diagnostic, again, like you stated, only 4, versus therapeutic, like you stated, only 4, right? In a rolling 12-month period. So again, we're trying to butt up against the frequency limitations, right?
Yep.
And then also when we dive into LCDs, there's always going to be that greater bucket of coverage indications, right? And then there's always that laundry list throughout LCDs. There's a laundry list of what is actually going to be covered, right? So in this particular case as well, there are multiple things, like for pain. They go on and state specific examples where, they didn't document the appropriate, conservative time period that the patient underwent for 3 months, and that conservative stuff failed. That conservative stuff, like you said, could be PT. It failed. I did it for 3 months. I'm still suffering. I'm still in pain. Or I went through my NSAID therapy. It did nothing. So providers need to make sure that they're reviewing their LCDs for this type of, laundry list of coverage indications that have to be met. Again, all of the buckets have to be met. If the LCD says all of this criteria has to be met, then you have to make checklists in the workplace. That's always what we do for our providers. We help them make checklists to guarantee that there's a way internally for them to check the box. In this case, we like this check the box, right? Check the box of how your documentation is actually supporting this criteria that is required for the service to be appropriately paid.
Well, and even further than that, not only do they have for this particular for these particular requirements, not only do they have it in the LCDs that they have to have failed conservative therapy, like you were saying, Sonal, but they also have to show sustained benefit from the injections, and at a certain percentage for a certain amount of time. So, I mean, their documentation gold there. It shows you exactly what needs to be in that documentation. And if it's not in there, you may get paid again. You can put anything on a claim form, a CPT, an ICD-10. If it meets that criteria, it's going to get paid, but are you going to get to keep it?
Right.
And so those are the kind of things that I see, and I know you see too, a lot when we're doing these audits, is not that they're not putting the right codes on there. It's that when you look at these other criteria about the failed therapy and the sustaining, percentage of relief that the patient is getting, and that it was for at least 3 months and blah, it's those pieces that are missing in the documentation, because the physicians and the AP, they don't know about these LCD kind of things, about those requirements that are out there, unless, someone in the staff has kind of informed them that, hey, we have to make sure that these other things are documented to support these. And so, yeah, the check boxes or some prompt that will come up in the EHR, if you use the EHR, to say, therapy, what kinds have been tried, what has worked, what not has worked, relief, how long, how much, put them in there for them to be able to fill it out. That way you're covering all those things, because, these are intense,
Yes.
procedures that are being done. And it's not like you're just pulling a splinter out of somebody's finger. I mean, you're injecting things into their facet joints, in their spinal column,
In their spinal column.
So
Right.
you hate to put that kind of concentration into things just to have to pay it back because you didn't document the fact that they had PT and it didn't work. They had NSAIDs and, they weren't helping them at all. That you're not meeting that kind of criteria, that, the document shows good for the actual procedures you were doing. It's that periphery stuff that is not supported in the documentation. That's one of the places where I find a lot of times they kind of really, I don't want to say fall down, but they're deficient.
Right. Exactly. And that's exactly where providers need folks like us. They need compliance professionals on their teams, right? Because, like you stated, these LCDs are complex, right? And so providers have to understand that based on their geographic location, they need to have someone look at the MAC's web pages and find where that LCD is, right? Understand it. Someone on that team has to understand it and then help the provider build these tools, these checklists, these prompts in the EMR, right, to help them, garner appropriate reimbursement the first time. Because, like we've said throughout compliance capers time and time again, you will be paid promptly within 2 to 3 to 4 weeks, right? But when a auditor on the payer side gets a chance to review things and ask for documentation, that's when things can go sideways pretty quickly, right? Because as we've addressed time and time again, when there is an LCD or an LCA involved, they are long documents, full of multiple criteria that providers have to meet to help support those particular CPT or HCPCS codes, et cetera, right? To make sure that they are appropriately coding things the first time. So, yeah, that's a great point, is that compliance is definitely a must in these rather complex facet joint injection procedures, right? And these types of codes also require imaging. That was not introduced throughout this report at all. But those of us who do code in the field, when we read these CPT code definitions, these are the particular sets of codes, 64490 through all of the add-on codes for these single injections to the cervical spine or the thoracic spine or the lumbar or the sacral, right? So the images are included in this particular group of CPT codes. So although it was not an issue here in this particular report, it was not looked at, it was not an issue. Okay. But I have seen and been involved in many a case where you need to make sure that providers are using the right group of CPT codes, right?
Right.
Because
Right.
if you don't use the imaging, there's another set of CPT codes that you should be using.
Right.
So, that's where things get a bit more dicey, but that wasn't the case here. So that's a good thing.
Yes.
Um, but yeah.
And I think the other thing that we wanted to make sure to kind of touch on here is that in looking at your records, whether you do them internally with someone on staff or you go to consultants to have them look at your stuff, that, not only do you look for things that are non-compliant being over-reported, but also under-reported. On page 9 of this report, if you look at it, they started listing where the non-compliance was. And if you look, for example, the first one that they list on that page is that physician billed for facet joint injections administered for fewer levels of the spine than the number of levels shown in the medical record. So they were underbilling.
Wow.
So if you look through that, out of the ones that they list, there are numerous times in there that services were underreported. So they were losing revenue. And so if an audit is performed, not only will it find these other areas where it's saying, hey, you're not reporting this correctly, or you're not meeting the requirements of those LCDs, but it also will pick up times when you're underreporting. So and that was 37% of the time in those records they looked at that they were underreported. So that's a lot of revenue being left on the table, and nobody can do that these days. So this is one of the areas where having an audit performed definitely pays for itself. So you're protecting yourself from the times when you reported incorrectly, maybe overdoing something and pulling back, versus also the times when you're not getting the reimbursement you deserve. And everybody needs to be doing that these days.
That's right. That's well said. Yeah. So these reports, like we've said, go into vast detail, right? And these footnotes in these various reports, these appendices, there are just juicy, juicy bits throughout the entire thing.
Yeah.
And you're absolutely right. The OIG identified under reporting, right? So that is huge if practices just developed a proactive embrace and started looking at their own documentation right before it gets sent out, before these claims go out the door. You need to make sure that you are reporting everything, right? So you get the maximum reimbursement that is allowed to you, right? Based on the services that you're performing. So yeah, that was a great point there for the underreporting. And I also liked the fact that the CMS responded at the very end of this report, the last couple of pages, and they concurred. They agreed with everything the OIG recommended.
Yeah.
From overpayments, they said, yeah, we'll go out, we'll collect. But more importantly, in my opinion, is they agreed that education, was not provided in 2021 regarding that new implementation of that LCA for the modifier KX, right? So it's a really good thing to read these types of reports in their entirety, especially if they are applicable to your pain management type of practice, or if you happen to be a coding specialist that does these types of things. And I know if there are any out here in the audience, this is a complex service line. It's always been in the news. Again, because of the complex nature of the coding and the supporting documentation that's required. So, yeah, I thought it was another wonderful report for you and I to talk about and help our audience just understand that the OIG work plan and work programs that they have in place throughout the year are wonderful. And we just have to wait until they finally close this one out in its entirety. Because again, there are multiple links and more of the work plan items that have not been closed out yet, but we're expecting the full thing to be done by 2024. So again, this year. So I know I can't wait to see what else they find in the outstanding work that they have to do on this one.
Yep. Yep. Yeah, they do a very thorough job when they look at everything. So, just make sure you're going through the report. If there's something in there that still hasn't been finalized yet, just earmark that to make sure, you kind of go back through and check on it every once in a while to see when it gets finalized, so you can go back through the parts that are now completed that were not the last time you looked at it, and just to make sure you're getting the whole picture for what your practice does to give you the comprehensive results that was given out of that work plan project.
That's right. Well, thank you so much, my friend Betty. I'm so glad we had this conversation together today on compliance capers, and I can't wait for next week's episode as well on another report that we will be diving deep into and talk about that closed report. So yeah. This was good. So yes. I hope everybody reads these OIG work plan closed reports. Yes. I think you'll gain a lot from them.
Agreed. Thanks. And we'll see y'all next time.
That's right. See you guys next time.
Bye.
Bye.